MIS decompression in lumbar stenosis secondary to espondilolistese. Is fusion always needed? There is something that these are my disclosures. This is one of the topics that there are more debatable in the scientific community, and there is a lot of fights between North America and Europe, as Dr. Pimenta had said before. You know perfectly which is the stenosis secondary to the spondylolisthesis, because it's a slip of one of the vertebrae against the other, and the reduction of the size of the spinal canal. Then we can treat it in different ways, mainly conservatively, but when this conservative treatment is not able to reduce the pain and the disability of the patient, we need to move to another type of treatments. We need to go to the surgery. Then we have two main types of treatments. Only laminectomy, which means to take out all the facet joints, bony compression, and ligament compression out of the nerves roots, and the other is also to fuse or without laminectomy. Which are the guidelines based on evidence-based medicine? Well, this is the North American Spine Society recommendation guideline that in 2015 there were no proper indication to fuse or not to fuse these cases. We need to go through all the studies has been published in the last years. This says as a systematic review with all the papers that have been done in a randomized way, comparing the treatment of the stenosis with or without spondylolisthesis. There are only these 5 studies randomized, and the quality of them are not equal. There is very good, this one of Gowala in 2016 published in the New England, but the other, like this one, is only the quality is only 4 because it was made in 1991. And then the results can be a mixture between a lot of things, but we can make a picture how is the problem. Now we know perfectly that the satisfaction with all the techniques is almost the same in both groups, in all the studies. The OS3 in preoperative is the same. There is no difference. In the postoperative status is the same in both groups. The duration of the operation, the blood loss, and the length of hospital stay is less in the laminectomy group without fusion than the other. And the reoperation rate, this is the more debatable point, could be a little bit higher in the laminectomy group, but not in all cases. We can go further in this. The last 2 studies has been published in 2016 in the same number of the New England Journal of Medicine. This was the study that Marquez commented yesterday about stenosis, and was made in Sweden. We note that there are 4 different groups. One is the patients with spondylolisthesis with laminectomy or with fusion, and the other 2 are the patients without spondylolisthesis with laminectomy and fusion. Well, at the beginning they are the same, and as we know, during the operation, the length of the operation and the blood loss is less. And one of the other points that we have to take in mind is how much resources we are consuming to give the best solution to our patients. Here, the length of the stay and the cost is less in the laminectomy group, in the descompression alone group. But nobody has gone through this comparison between the cost of both. One is double than the other. The other group was conducted by Dr. Wenzel in USA, shows that there is a slight difference in SF36 physical component summary score at 2, 3, 4, 5 years. It's slightly, but it's meaningful. What does mean? In the ODS is the same. The other scores that the other studies show is the same, but is less than the other. This, in this paper, they lead that it's possible that fusion could have better results, but it's not. But the problem real is this, the cost is really high. You can see the charts here. There is a slight but meaningful difference in in the first years. It's not so much because it's not statistically significant. But in 2 and 3 and 4 years, it's statistically significant. In always is the same. But one of the controversies in this study, and they criticize, is the amount of reoperation in the descompression alone group. It's about 30% in 4 years. It's really high compared with the other publication that has been done in the recent years. But in the fusion group, there is almost none in the first 3 years, and then start to going up about half of the decompression group. Well, there are two main differences in these two groups. When you reoperate the decompression group, you are reoperation and doing the reoperation in the same level, maybe because there is an instability, or maybe because your decompression was not so good as should be. And the other in the fusion group is more likely to operate on the other level, above or below, mainly above. But there are the randomized studies. What is happening now in a real world? In a real world, we don't know how it's going, but with this quality outcomes database that was produced by USA, with the data of a lot of hospitals, we know, in this case, we know you compare all the patients that have been operated in these hospitals for a period of time. Then we know there is, in 426 cases, decompression alone was conducted in 84 and fusion in the other 342. The results are almost the same, only in the preoperative status, the pain in the pack is a little bit higher in the patients with fusion than the other, and the result is a little bit better with fusion or in the back pain. But if you see the charts, it's almost equal. Also, the problems with the blood, operative time, and length of stay in the hospital is the same. But there is no difference in the reoperation in 12 months. What does that mean? It's because there is something more than randomized in these cases. There is something that the people who are operating these patients know, that we know that some patients shouldn't be operated only with laminectomy. For example, patients with horizontal facets, with fluid on the facets, or with other problems in the adjacent levels? Probably yes. But there is a huge number of patients that don't need to be fused. Even in USA, 20% of the patients, they need it. Then I'm only talking until this point about open decompression. But when we go through MIS decompression, we know that the idea is to get the same result with less damage to the to the tissues that are not involved in this problem. with this approach with tubes in USA or in Europe more with Casper retractor, is the same, the results are the same. We try to achieve the same. The main criticism to this is if you can reach the same release on the other side. We published this paper several years ago with the same results in the same on the contralateral side of the approach. Now, the next step is to compare lumbar stenosis open versus MIS. That was conducted by Dr. Roy Hartle in New York. He performed his own series and put all these series together, 14 with open, 16 with MIS. And the results are very impressive. The reoperation rate is about, in the open group, almost 13%. It's almost the same, half of the randomized studies, but if you go in the minimally invasive laminotomy, it's about 3.3% for fusion. If we take into account all the reoperation, it's about 16 and 6%. It's a huge difference. And the satisfaction of the patients is slightly better in the MIS. We don't know exactly why. Maybe there is something in supratentorial point. If we compare both charts, there is something that it doesn't match. We know that we can do better than in the randomized study conducted by the USA group than these ones. And the result with the MIS is really low. One step forward, we can do a fusion in one level and to decompress in the above. But we know that espondilolistese is not a problem in one level. Sometimes it's a problem in the whole spine. Then if we have these problems, we need to lead with deformity cases with longer constructions. We know also that the MIS fusion compared with the open, it's almost the same, but in one level. In two levels, it's better for the outcome, and the same problems we have resolved with less blood loss. And in this database in USA, the time of the surgery is the same in MIS than as in open MIS. That's one of the criticisms that the people gave to us when we were doing MIS. Well, there is no study conducted open versus open versus fusion in terms of economics. But we have done in MIS fusion, and with MIS fusion, it's less consuming resources, less money than in open ones. Not because the hardware is more expensive, but because we reduce the complication, the reoperation, and when the patient came into the hospital again. Also in USA and in Europe, in United Kingdom and Italy. Why? Then, this is my final slide. Why to put excuse in all patients if there is a great number with similar outcomes without them? There's one thing that we have to answer. The reversion rate is very similar, and within MIS is even less. MIS reduce the blood loss, length of stay, and operative time. Can this impact in the outcome? May not in the outcome, but yes in the resources that we are going to consume to treat these patients. Cost effectiveness should be proven comparing both techniques, and there is a lot of bias. As Pimenta said, surgeons have different options. Patient bias and social. For example, if a patient is operated in my country, in Spain, and put excuse on the back, they are going to be retired, not return to work. then some people look for their retirement before to go to work. This is some point that we cannot control in our studies. Thank you for your attention.